Next slide, please. Our first speaker is going to be Mary Kiklowski, president and founder of Running on Air, and make sure you discuss any new conflicts of interest. Mary, you're on. 5 minutes.
All right, thank you. Well, my name is Mary Rose Kitlowski, and I appreciate the opportunity to speak to you today. I have no new conflicts. I am 57 years old with bronchiectasis, and I have one sibling who also has bronchiectasis. My sister and I have a rare genetic lung condition called primary ciliary dyskinesia, or PCD. Our cilia don't move properly, and this means our respiratory system is unable to filter out dust and other particles we breathe in, the way that most normal functioning cilia and lungs can. Despite having a chronic cough and runny nose from infancy, I wasn't diagnosed with bronchiectasis until I was 17, after having my first chest x-ray. The doctor started looking to see what had caused the bronchiectasis and ultimately discovered that I had PCD. After my bronchiectasis diagnosis, my parents took my sister in to be checked. She was found to have bronchiectasis at the age of 14. We, of course, have no idea how old we were when we first developed bronchiectasis. Many with PCD develop bronchiectasis before they become teenagers, and most have bronchiectasis by their 20s. By the time I was 20, I started on IV antibiotics to treat exacerbations. Every time I had an exacerbation, which started off about once, maybe twice a year, I would be hospitalized for a few days so they could do a sputum culture, x-rays, and pulmonary function tests and start IVs. I started my first full-time job while on IVs because I started out with peripheral IVs. A nurse would need to change the IV every 3 to 5 days. I would either need to take off from work to come home for the nursing visits, or on a few occasions, the nurse would actually come to the office. Eventually, I progressed to PICC lines. I would be hospitalized for a few days so they could start the antibiotics and schedule the PICC placement. Then eventually, the PICC line stopped being effective. They couldn't get a PICC line in my right arm, and they were having difficulty in my left. In December 2019, I decided to get a port, which is one of the best medical decisions I made. I wish I'd gotten it sooner. I continue to need IV antibiotics, usually about twice a year now. One of the reasons I got the port was because I had reached my out-of-pocket cap on my insurance. I figured, why not get it while it was free? While I don't always reach my out-of-pocket limit each year, I usually come pretty close. After my sister and I were diagnosed, our father always said we should get a federal job because we would be guaranteed health insurance without pre-existing disease issues. I worked a full-time job for the federal government for 31 years. From 2021 to 2024, I was on the leave transfer program. Thanks to the generosity of friends, coworkers, and my brother-in-law, they donated enough leave so I could continue working and take the time off I needed for exacerbations, appointments, and fatigue. During those 3 years, I was unable to work a 40-hour week and barely had the minimum hours required to still be considered full-time. I realized, though, that despite the reduced hours I was working, all of which was from home, I was too tired to go to the gym or to do almost anything. I needed to take care of myself, and in February of 2024, I left my job on disability retirement. I've been on supplemental oxygen for over 11 years now. I'm lucky that I don't need it 24/7, however, my needs are increasing. There's a lot of planning involved when going out. Traveling has gotten harder. My oxygen needs are mostly low enough that I can use a portable oxygen concentrator, or a POC, the only device that's allowed when flying. I can usually manage the extra batteries on my own. However, when my husband and I went to Australia this summer, he carried my 10 pounds of supplemental oxygen batteries, along with all the other medical equipment. Every day of our trip, he carried 2 to 3 batteries for me to change out for my portable oxygen concentrator, since the batteries only last about 2 to 3 hours. My husband, I started seeing a transplant team in 2019. Despite still being deemed too healthy to be listed, I see the transplant team twice a year and go through periodic tests like echocardiograms to track the progress of my disease. I only had 5 minutes to share with you what living with bronchiectasis is like, and there is so much more to share about the impact on me and my family. But I hope that this gives you a small glimpse of the burden. Thank you.
Mary, thank you so much for being here and giving us your life story and patient perspective of the difficulty of your disease and bronchiectasis in general. Thank you so much. Our next speaker will be Amy Lightman. Amy?
Thank you. 45% of our funding is received from industry. That's my disclosure. Good morning. As the president of NTM Info and Research, which is a patient advocacy and support organization for patients and caregivers with NTM lung disease, bronchiectasis, and other related comorbid diseases, and as the daughter and caregiver of a longtime patient, I appreciate the opportunity to provide additional input and perspectives to this important discussion today. Janet Woodcock, the former director of the Center for Drug Evaluation and Research at the FDA, once famously stated that patients are the true experts in their disease. Patients have long recognized that the exacerbations of their bronchiectasis are tied to the decline in their quality of life and their lung function. Bronchiectasis marks another milestone in the long, arduous journey our patients have faced with their health, and it is one they have long asked for. We know this because we've asked them. In 2015, at a patient-focused drug development meeting on nontuberculous mycobacterial lung disease, patients were also quite vocal about their bronchiectasis. Quote, "As long as there's bronchiectasis, and we don't even have a clue about it, it seems to me, about bronchiectasis and how to deal with it, that's the underlying disease I have, and that's there." Another quote, "I don't hear anybody really, as far as the medical and the pharmaceuticals, trying to deal with this cascade in the lungs, inflammation in the lungs. I think it's perhaps the number one thing that we need to do for bronchiectasis patients." In 2019, NTMIR undertook a patient survey collecting both quantitative and qualitative feedback. Here is some of that feedback in the patient's own words on if their treatment could change one thing. Quote, "Maybe a medication that would reduce bronchiectasis or reduce cavities." Quote, "I am most concerned with total lung health. Getting this infection under control means I am less likely to have exacerbations that in turn require additional antibiotics in the future." In a 2018 publication in Chest presenting a needs assessment survey, respondents ranked the treatment of exacerbations among the highest priorities. So it seems to me in the last 10 years, people have listened to the patient's wants and needs, and they have responded. There are a few additional facets to consider in the evaluation of bronchiectasis, and I would draw your attention to some of these. Excluded from this evaluation is an antimicrobial resistance in this model, which has relied extensively on a publication that notes the need for significant antibiotic use by bronchiectasis patients. The report specifically references MRSA, but bronchiectasis patients are also more vulnerable to several other resistant infections, including at least 4 of the 6 listed escape pathogens. I previously questioned the number of days of absenteeism for outpatient visits for exacerbation. While this number was doubled from 1 to 2, I do not feel that this still presents a realistic picture of the patient's lived experience, which often includes profound and unpredictably variable fatigue. As I mentioned, an exacerbation is not typical. It's a vicious cyclone of inflammation that continues unabated until something finally disrupts that cycle, and after that disruption, the patient still must recover from the damage that has been done. As one patient noted in the 2019 survey, quote, "It has damaged my lungs permanently." Next, I would like to address the issue of quality adjusted life years. The issues surrounding the use of quality are well known and documented, so I will simply say this. I am not qualified to determine whether a patient's quality of life is good enough. You are not qualified to determine this. Only the patient can make that decision in the end. Finally, I'd like to address the issue of cost versus benefit. A recent Bloomberg article discussed the tsunami of approved cancer treatments and noted that fewer than half of the drugs that they evaluated that had been approved since 2000 have ever been shown to extend patient survival for any of their approved uses, and even fewer were shown to improve quality of life. One such drug listed at $160,000 a year in 2020. It currently lists at $214,000 a year, with data showing that while it might shrink tumors, there are no clinical trials showing that it extends life expectancy. This is not an anomaly in the cancer space. This is actually the norm. Yet payers, including Medicare, spend staggering amounts of money for treatments with unproven effectiveness or with demonstrated ineffectiveness. Cancer patients are given the opportunity to take treatments with incremental or minimal benefit, and no one is telling them that they shouldn't, because we shouldn't tell them that. Today, we're discussing a drug with a benefit sought by patients that is shown to have a benefit. So I have to pose the question, with this new treatment that has a demonstrated benefit for bronchiectasis patients that they want, isn't it worth it to them? Thank you.
Thanks, Amy, for your very erudite comments for us all. Our next speaker is going to be Alicia Malanga, Executive Director of Bronchiectasis and NTM Association. Alicia?
Thank you very much. I appreciate being here. My disclosures are correct, and there is no update to the disclosures that are listed above. Although I will say that there are more companies than that. They're just not all listed there. So just so you know. So thank you for allowing me to speak to you all today. As you noted, my name is Alicia Malanga. I'm the Executive Director of the Bronchiectasis and NTM Association and the Chief Corporate Relations Officer for the COPD Foundation. We are committed to our patient community and to advancing high-quality care, research, education, and advocacy within the bronchiectasis and NTM lung disease communities. On behalf of both the COPD Foundation and the Bronchiectasis and NTM Association, it is truly my pleasure to be able to speak to you all today. As we listen and talk today, I ask you to keep in mind the significant burden that patients with bronchiectasis and their loved ones face every day. We've heard some of that today. The weight of this disease can be all-consuming. Bronchiectasis has been characterized by a vicious vortex, the vicious vortex of inflammation, recurrent infection, impaired mucociliary clearance, and structural lung changes. A vicious vortex is a fitting representation of the complex interactions involved in the pathogenesis of bronchiectasis. The vicious vortex is draining and it's frustrating. Our patient community shares that they have recurrent coughing that significantly impacts their quality of life. Recurrent coughing. I ask you to take a moment to picture the burden and social impact that recurrent and persistent coughing could have on a person and their family. The patient's journey to diagnosis of bronchiectasis is often long, frustrating, and riddled with inaccuracies. We are talking about real people with families and loved ones. Because of this reality, the burden of disease extends beyond the patient. Caregivers of patients with bronchiectasis experience their own burden. They also may have decreased quality of life and even professional impacts such as lost wages and decreased work productivity. But today, as I stand here, there is some hope that this burden of disease can be minimized or even lifted, and we are so grateful for that hope. We appreciate the opportunity to comment and hope that ICER will consider our comments related to accurately characterizing non-CF bronchiectasis and its disease burden. As you continue your process today, we ask you to consider the real-world burden of disease as likely underrepresented in the ICER model. We believe this statement to be true because of the following. ICER assumes baseline rates of exacerbation and disease progression based on the placebo arm of the ASPEN trial. Applying treatment effects to a trial-based comparator both underestimates the true burden of untreated disease and dilutes the relative impact of treatment. The ICER model also appears to underestimate the duration and burden of exacerbations. Patients report a meaningful burden of disease beyond the exacerbation due to the illness itself, the corresponding requirement for physician care, and the uncertainty of when an exacerbation will occur. Lastly, ICER assumes 90% of exacerbations resolve within 1 month. Real-world evidence shows that exacerbations often last multiple weeks with lingering symptoms and incomplete recovery over a longer term for many patients. As you hear the comments today, we ask that you consider that the true health and economic impact of exacerbations is likely underestimated in this model. This is a community who up until now has had no targeted pharmacological treatment for their bronchiectasis. It is a community who shoulders a tremendous burden of disease. It is also a community who now has hope. I thank you again for the opportunity to speak today and for consideration of these comments.
Thank you very, very much, Alicia, for your very thorough and impressive comments that will help CTAF in making their decisions. Our next speaker is Shelby Stout, a patient representative. Shelby, thanks for being here.
Thank you for the opportunity to speak about bronchiectasis and my experience with living with this disease. So I have no conflicts of interest, sorry. At 51 years old, I have already lived a full life and have been physically active my entire life. That all changed when I was diagnosed with bronchiectasis. For most of my career, I worked directly with animals and pushed the limits physically many times over the 20 years. While juggling motherhood, including being a Girl Scout troop leader. Needless to say, I stayed busy and social. Things changed in 2013 when I first started not feeling well. For 5 years, I went through the barrage of tests that come with diagnosing bronchiectasis. They ruled out heart, thyroid, and immune system conditions. All this while I continued to work full-time, raise our daughter, and battle depression. The last thing I needed was a progressive chronic respiratory disease in the form of non-cystic fibrosis bronchiectasis. But that's what I've got. I recently heard someone say that it's like being unexpectedly dropped in a foreign country that no one was heard of and don't speak the language. Everything about this disease is exhausting. People think I'm mispronouncing bronchitis or that it's a made-up disease because there's little for people to see. They don't see all the different tests, medications, and treatments. They do see the 30 pounds I gained as a side effect after 10 courses of prednisone in 1 year to treat inflammation, only to learn that prednisone is not effective for the type of inflammation associated with bronchiectasis. This is the stuff that takes its toll on my quality of life and those around me. They feel helpless and confused about what things affect me when. The nebulizer smell makes my husband nauseous. The gadgets clutter the house from air filters to treatment devices to having to keep the windows closed. All this to help avoid exacerbations because I know if I get an exacerbation, it'll knock me out for a good 2 months. I even had to go on disability at work at one point because I was missing so much of it. I used to want to travel the world. Now I dread travel or even simply going out to dinner. It's like I'm writing a story every time I go out, always thinking of the 5 W's. Who will I come in contact with? Will it be crowded? What will the weather be like? Rain causes my chest pressure to increase. Fungi spores rise from the dirt and cool, damp air, so I wear a mask. Hot weather makes the air dry and difficult to catch my breath, so I wear a mask. Wind blows pollen, bacteria, fungi, spores, dust, and everything else that aggravates the lungs, so I wear a mask. When will I be going out? If early, I may need to adjust my airway clearance treatment and factor in recovery time. After 7 p.m., I'm pretty wiped out from daily activities already. Where will we be going? Is there indoor or outdoor seating? Is there a fire ring nearby causing smoke exposure? Will a fan agitate my lungs? Will the restaurant be crowded with people coughing or sneezing? Why am I going out? It's always a cost-benefit analysis that takes energy to process. It is amazing how much energy a simple conversation takes. Will the restaurant be noisy, requiring me to speak louder, which takes additional energy? Will I be with people that have difficulty hearing my tone of voice, causing me to have to repeat myself, which takes even more energy? During all of which, a coughing fit could set in at any time, interrupting conversations, draining energy from me, making others uncomfortable or concerned, often resulting in an irritated throat, dry heaves, sometimes vomiting, and most likely incontinence. Coughing hurts. Sneezing hurts. My whole body often hurts. I still want to travel the world. It will just look different. How will we be traveling? Will there be enough outlets for my air anodizing air purifiers? How long will I be gone? What airway clearance equipment will I need? How many of what type of masks will I need? And always extra underwear for that pesky incontinence. But the hardest thing was hearing my daughter say, I lost my mom at a young age and had to grow up faster. We used to go hiking, climb trees, build forts, go camping, and that all suddenly stopped. We used to love to sing Girl Scout songs together, all of which we no longer do. The only relief I found was while taking brensocatib during the Aspen clinical trial. Thank you.
Thank you very, very much, Shelby. I'd like to make a comment in that this particular part of the CTAF and ICER meetings, public comments, are not only important, but they're a vital component of our meetings. The testimony today of Mary, Amy, Alicia, and Shelby have been incredibly meaningful and insightful for all of us here at our CTAF panel. And we thank you for sharing your perspective of living with bronchiectasis. Before we break for lunch, Dan, do you have a final comment about industry?
Yeah, so I just wanted to offer a clarification. So I was mistaken before. Insmed, the manufacturer, did respond to our data request and provided some useful information. So apologies for that, for having misspoken in that regard. I do want to maintain that we do wish that they had been engaged with us with other opportunities that we offered, including and perhaps most importantly, being with us here today.
Thanks, Dan. I appreciate those comments. We're going to break for lunch, and I'm going to ask our East Coast people to return at 2:50 p.m. and our West Coast panel to return at 11:50 a.m. To resume and have our vote on clinical effectiveness. See you later.